Medicine in 2014. Your presenters today are Tierza Stephen and Leslie Flores. Tierza is a hospitalist at Abbott Northwestern Hospitalist and a fully engaged volunteer leader at the Society of Hospital Medicine. She serves as consultants and has been an active volunteer at the Society of Hospital Medicine for many years now. And report. Take it away. Thanks.
Thank you, Patrick. Thank you. So historically, since its inception, the Society of Hospitalist Medicine, or SHM, has continuously surveyed and tracked data concerning hospitalist productivity and compensation. Its first survey was published in 1997, and subsequent surveys have been published on average every 2 years. The current 2014 State of Hospital Medicine report contains the results of its 2014 survey based on 2013 data, as well as information licensed from Medical Group Management Association, or MGMA, about compensation and productivity for hospitalists. So what actually is the State of Hospital Medicine report? It's widely regarded as the most authoritative source of information regarding the current state of hospital medicine in the nation. Leslie will get into more detail next about report content. So suffice it to say that the survey contains the most up-to-date information on subject matters that most interest hospitalists and those working with hospitalists, including productivity, staffing, and compensation. The intent of this report is to educate readers about characteristics and trends in the rapidly evolving specialty of hospital medicine. Over the years, we've honed the survey, refining the questions to best solicit information and adding and deleting questions from the survey to maintain relevancy. The report ends up being used as a benchmark. It shows what other people and other hospital medicine groups are doing. It's only common curiosity to want to know what your peers from your region and even nationally are doing, especially when problem-solving schedules, staffing, and other hospitalist issues. This report lends insight. How is the report generated? SHM's Practice Analysis Committee is responsible for the State of Hospital Medicine report. The Practice Analysis Committee is comprised of practicing hospitalists from all types of practice settings, as well as non-physician practice managers and healthcare executives. The committee members work with SHM staff to design and carry out a survey of hospital medicine groups across the nation. We review past surveys and then discuss and agree on topics to be surveyed. We then send the survey to hospital medicine group leaders, both physician leaders and non-physician practice administrators and executives, who are in SHM's group leader and academic hospitalist database. In addition to respondents from SHM's database, we also publicize, invite, and receive data from respondents who visit SHM's website and learn that the survey is available to be completed. Concurrently, we reach out to potential respondents via email, snail mail, and phone calls, letting them know that the survey has been released and encouraging and supporting survey completion to maximize response rates. Usually the survey is open for response from January through early March of the year of the report publication, with respondents sending in information from the preceding year. Once we've collected all the completed surveys, we analyze the data and create data tables and graphs. As we analyze the data, any outlying data is dug into a little deeper by contacting the respondent and asking for clarification. All information submitted is kept strictly confidential. It is only reported in aggregate along with information submitted by other respondents. Only SHM staff members see the individual survey responses, and only for the sole purpose of aggregating data and performing statistical analysis. The next step in the survey process is acquisition of compensation and productivity data from MGMA. MGMA maintains its own survey development process, and MGMA is widely held as the industry standard in benchmarks on physician salary and productivity. Finally, we compile the information and draft the State of Hospital Medicine report. So who responds? Well, in 2014, SHM received 499 eligible survey responses, and these 499 hospital medicine groups reported employing a total of 6,341 FTE physician hospitalists at the end of the year, at the end of the survey year, which was 2013. We don't calculate a response rate because we don't know the denominator for the calculation. Essentially, we don't know the total number of potential participants who received the information asking them to complete a survey about their group. However, using the 2014 American Hospital Association survey data and adjusting for response rate and projected growth, SHM estimates that there were approximately 3,600 hospital medicine groups and 44,000 physician hospitalists providing services in U.S. hospitals in 2013. Using these numbers, we estimate an approximate survey response rate of 13.9% of the total population of hospital medicine groups, with responses representing about 14.4% of the nation's hospitalists. And now I'll turn it over to Leslie, who will tell you more about the reports.
Thank you, Tirza. I'm going to just take a couple minutes and talk a little bit about what type of information is in the report and point out some new features that are in the report this year that have not been in previous years. So as Tirza mentioned, the report really is a combination of the results of SHM's 2014 survey and data that SHM licenses from the Medical Group Management Association. So for the SHM portion of the survey, the data is broken down into hospital medicine groups that serve adults only, hospital medicine groups that serve children only, and hospital medicine groups that serve both adults and children. You can see the vast majority of the respondents are in that first pool of hospital medicine groups that serve adults only. On the MGMA side, the data is broken down basically by specialty. So we have a special cut of the data that's not normally reported by MGMA, which is all adult hospitalists, that is internal medicine and family practice combined. And there were about 3,337 of those folks that MGMA collected data for this year. Then separately, the report shows data, productivity and compensation data for family medicine hospitalists, for internal medicine hospitalists, for pediatricians, for dual boarded med-peds hospitalists, and then provides information for hospitalist NP and PAs. And then we also license data from MGMA's academic survey so that we can report productivity and compensation information for internal medicine hospitalists, academic hospitalists, and academic pediatric hospitalists. So when you look at the SHM side of the survey, the major categories of information that are included are listed here. And it's important to point out that for the SHM side of the survey, pretty much all of the information is reported at the group level. So we're asking about what the group's practices are, not about information for individual physicians. The individual physician level information or provider level information is the information that MGMA collects. So SHM asks about scope of services and about the way hospital medicine groups are staffed and scheduled. There are some questions about compensation and benefits in a broad sense. That is, we're not asking how much did each individual doctor make, but we're asking what was the average distribution of base pay versus productivity type compensation versus quality incentives and things like that. The survey also asks about CPT code distribution and about the finances of hospital medicine groups. And that's one of the pieces of information that's probably the most commonly sought after every other year when the survey comes out, which is what is the annual financial support number for hospitalist practices across the country. There's also this year, for the first time, there's information about academic HMGs, which has always been in there. And then for the first time this year, a number of questions were asked about various innovations that are related to hospital medicine and the way hospitalist practices interact with the hospitals that they work in. So, for example, there's information about ACO involvement and about electronic health record implementation and things like that. And then finally, there's the information that's licensed from MGMA about compensation and productivity for individual doctors. So this is a infographic that gives you a brief summary of the clinical services provided by hospitalists in this new survey report. So the blue numbers are the percentages that are provided by adult practices that are serving adults only, and the orange numbers are the percentages of practices serving children only that provide those particular types of services. So we've seen a big pickup this year in hospitalist groups doing things like outpatient work and post-acute care work, and work in different types of specialty units or facilities like rehab units and things like that. Also some increases in palliative care work. And then some areas are going down a little bit. I think the care of patients in the ICU went down a little bit from the previous report a couple of years ago. But this is information that's in the survey. And then we also wanted to show the physician specialties that were practiced in hospitalist groups. And what this graphic shows is that, again, the blue numbers are for adult practices and the orange numbers are for pediatric practices. But one of the really interesting findings is that 59.2% of adult practices, that is almost 2/3 of them, reported having at least one family medicine doctor in the practice. And not shown on this particular graphic, but also in the report, now fully 2/3 of adult hospital medicine groups report having either NPs or PAs or both working in the practices. So another new question that was asked this year for the first time was about jeopardy or backup systems that hospitalist practices might have in place to help with surge protection. And you can see from this graphic that about 40% of adult practices and 70% of pediatric practices said they have no formal backup system in place at all. And then the others reported having either a completely voluntary backup system where people could sign up to be on backup call but were not required to do so, or in a smaller proportion of cases having a mandatory backup system where people are required to be scheduled to be on backup call of some sort for the hospitalist practice. So for adult practices that have backup systems in place, which is the highest proportion of the backup systems, 28% provide no additional compensation at all for being on the backup system or being on the backup schedule, and about 60%, 59%, provide no compensation for being on the schedule, but do provide additional compensation if the doctor is called into work. So that's new information that we never had before, and we're pretty excited to be able to share that with you. I can say from the work that I do that dealing with surge capacity and how hospitalist groups deal with things like unexpected absences and unexpectedly high volumes is an increasingly common issue that groups are struggling with all across the country. So it's really helpful to have this information. And then, of course, people are really wondering about the amount of financial support that's received by hospital medicine groups. And this graphic shows that in 2012, we reported across the country for adult hospital medicine groups, the average or the median amount of financial support was $139,000. And in the 2014 report, it went up to $156,000. Now, that does vary quite a bit by things like part of the country and the size of the group and some other factors, but for all adult hospital medicine groups across the country, boy, that's about a 12% jump in financial support per FTE physician in 2 years. And you can see that for the pediatric groups, the number actually went down slightly. I don't think it went down enough probably to be statistically meaningful, but seems to be holding pretty steady for pediatric groups. Also interesting to note that 94% of the groups responding to the survey, the adult groups, said that they had a financial shortfall. In other words, they didn't earn enough from professional fee revenues alone to cover all their costs. And 80% of pediatric practices said the same thing. So I mentioned before that we had asked new questions about ACOs, and 36% of adult medicine hospital medicine groups reported that one or more of the hospitals they work in was actively involved in or considering an ACO. About 48% of pediatric hospital medicine groups reported the same thing. I think that's because if you look at the data, pediatric groups tend to be in larger hospitals, often in academic centers or large community teaching hospitals, and those types of places are more likely to be involved in an ACO than smaller hospitals. But the concerning finding for us was that about half the time, the hospitalists either didn't know what their role was with regard to the ACO, or said there is no clearly defined role for the hospitalist within the ACO structure. So that represents an opportunity for hospitalist groups, I think, to get more involved in the ACOs in those places where they have them. We also asked about electronic health records and found that electronic health record in one form or another is nearly universal in the hospitals where our hospitalists work. It might be only CPOE, or it might be only electronic documentation or some other factor, but some form of EHR adoption is almost universal. And that the hospitalists actually are often key players. You can see from this graphic that frequently the hospitalists serve as super users and participate in the development of order sets, decision support, and protocols, and not as often, but a significant amount of the time, hospitalists are serving in IT leadership roles in the organization. So interesting information to have about the way hospitalists are involved in electronic health records. We also asked this year for the first time about other hospital-focused practice specialties, that is, hospitalists in other specialties besides medicine and pediatrics, and learned that a high proportion of the hospitals that our hospitalists practice in also have critical care intensivists, and about 16% or so have surgical hospitalists or trauma surgeon hospitalists, and neurology is actually the other most common one for our adult medicine hospitalists to interact with. Often for the pediatric practices, you're seeing a lot of them have OBGYN hospitalists in their settings where they practice as well. And then the MGMA data shows us that compensation for hospitalists continues to rise. So the median national compensation for adult hospitalists, that is internal medicine and family practice combined, in 2012 was just under $234,000, went up to almost $253,000 in the 2014 survey. But at the same time, productivity has stayed relatively level. So there was a very slight increase in work RVU productivity this year for those groups, and the productivity, if measured by encounters, actually went down slightly. But it's a relatively, it's not growing to the same degree, certainly, as compensation is growing. So I have to say that that 1,922 number down there, a little concerned about that because if you look at the MGMA data, the number of work RVUs went up slightly, and the average number of work RVUs per encounter went up slightly. But MGMA also reported that encounters, the number of encounters, went down a little bit. So I'm a little skeptical of that number. I think it's accurate in terms of the information that MGMA collected, but I think there's something that might be a little odd about that number. In past years, you can see the number of encounters has been around 2,100, 2,200 pretty consistently, and then this year it took a pretty significant dip. So we wanted to, now that we've shared with you what's in the report and some of the key findings, we wanted to share with you some case studies that show how this information is being used in Tirz's practice and in the work that I do. So I'm going to turn the presentation back over to Tirza now to talk a little bit about her case studies.
Okay, thank you, Leslie. It's always really interesting to just go through some of that high-level detail of what's in the report. It's always very interesting. I'm going to go through just two case studies at a high level. So I'd like to share with you how I've used the report in the past and found it to be very helpful. So I'll just go through two examples briefly. First, I was charged with creating a new hospital service at a small hospital, and that hospital wanted to have 24/7 hospitalist coverage, and they also were concerned about knowing what the cost of the program would be. So how did the report help me with this task? Well, the report showed the most recent information about how many small-sized hospitalist groups there were in the nation, as well as how many hospital medicine groups had 24/7 coverage. After putting together and vetting various hospitalist schedules and determining how busy the hospitalist assigned to the night shift would be, considering that the hospital administration wanted 24/7 in-house coverage, the figures could be compared to regional and national data found in the State of Hospital Medicine report. At the time, only 60% of hospital medicine groups provided 24/7 in-house coverage. Additionally, the report allowed a comparison between what the hospitals would be projected to generate in professional fee revenue versus what market competitive hospitalist compensation would need to be in order to attract candidates to the service. All this information is in the report. The report also gave insight into the viability of the proposed schedules, since it contained information regarding typical shift length, number of shifts, and the proportion of day and night shifts. So next slide. As another brief example of the usefulness of the State of Hospital Medicine report, I was asked to look into implementing a nocturnist model for a hospital medicine group. Again, I used the State of Hospital Medicine report as my main resource. It gave information regarding the number of hospital medicine groups who employed nocturnists in my region and also across the nation, the percentage of the total night work for a service covered by nocturnists, and that was actually quite interesting because some people think that if you have nocturnists they do all the shifts, but that's clearly not the case when you look at the data. The report also shows the differential, the shift differential between the typical number of shifts worked by a nocturnist compared to non-nocturnists, productivity differential, and paid differential. And all of these were critical considerations when devising nocturnist model. And now I'll turn it back over to Leslie.
Okay, thanks, Tirza.
Thank you.
So my case study, what I wanted to do is just show you a little bit about the way we use this data. My consulting partner, John, and I think, are in this report every single day in the work that we do. And so I've created some sample data here for you to see. This is a theoretical hospitalist group that we would be working with. And you can see that the left-hand column shows the core, that is the regular full-time employed hospitalists that are part of the group. and what their annual number of encounters per FTE was. And then if you include, excuse me, if you include other physicians like locum tenens and moonlighters who often work night shifts, that encounter number goes down a little bit. And then when you take into account the advanced practice clinicians, other resources in the practice, you can see that the number of encounters actually goes down a little bit more. And we compare that with MGMA data about encounters per physician, per hospitalist. And again, I'll point out this kind of questionable encounter number for the national MGMA data. It's very different from previous years and also different from the information for the South and the Southeast where this theoretical client was located. We also then look at let me go back to this slide and point out that the number of encounters that the group is providing is pretty reasonable. I mean, it's not as high as the median data in the South and Southeast, but we know that hospitalists in the South and Southeast tend to be much more highly productive than hospitalists in most other parts of the country. But compared to historically what hospitalist practice has been doing across the country, generating 21 or 2,200 encounters annually, they're pretty productive, reasonably so. But when you look at their work RVU information, you'll see that the work RVUs are well below not only regional norms, but also national norms as well, as reported both by the MGMA data that's in the State of Hospital Medicine report, as well as data from the American Medical Group Association. So we're looking ourselves here saying, what's going on? Their encounter data looks pretty good, but their work RVU data is well below what we would expect it to be. And they're getting a lot of grief for that in their practice because people monitoring their practice are only looking at work RVU productivity and aren't really paying attention to encounters. So we found that for this particular group, that they are generating only about 1.68 work RVUs per encounter when hospitalists across the country are generating about 1.98, and in the South, 1.99, so just under 2 work RVUs per encounter, and they're down here at 1.68. So that explains the difference in productivity when you look at it from the encounter point of view versus the work RVU point of view. Then we looked at the group's compensation and found that their compensation is pretty much in line with, a little above national norms, but pretty much in line with regional norms for their part of the country. So they're getting paid pretty well. So then we wanted to look at other aspects of the hospitalist program's finances. And another piece of information that is in the State of Hospital Medicine report from MGMA is the average collections per encounter and per work RVU. So we can see here that across the country, hospitalist groups collect almost $52 per work RVU, and this particular group is collecting only just around $36 per work RVU. And in the South, it's a little bit lower for about $45, but still higher than what this particular group is experiencing. So then it was no surprise at all when we put all of their financial information together that we found that this particular group had a much higher requirement for financial support from their hospital than other hospitalist groups across the country. So we already mentioned that the national number is about $156,000 per FTE nationally. In the South, it's a little higher than that, about $174,000. For hospital-employed hospitalists, it's actually a little lower, $142,000 roughly. And this particular group was all the way up there at about $238,000. So we want to pull all this information together and say, how do we make sense of this? And one way that we do that is to establish a range of expected performance for a similar practice. And typically for doing that, where we have data available to us, we use the 25th median and 75th percentiles for that all-adult hospitalist data from the State of Hospital Medicine report. So you can see in this case, the low work RVUs about 3,000, the high about 6,600, The median's about 5,100, but this group's producing only about 3,774. And then you take that low number of work RVUs per FTE and combine it with a low net collections per work RVU, and you'll see that the actual collections per doctor that's coming into this practice is well below the median and pretty close to what would be the low end of the range. At the same time, the compensations up here pretty close, a little bit above the median. Benefits seem to be in line. Now, I will say that the benefits, malpractice, billing expense, and other provider lines on this analysis are not things that are available in the State of Hospital Medicine report. So this is just an example for you of how we pull together information about a hospitalist group's finances and compare it against our experience in other places. But it looks like their benefits are pretty much in line in their malpractice insurance, but their billing expenses and other expenses are kind of high. So when you look at their overall financial support requirement, it's high, as we already mentioned. And the first place to look is at improving the revenue coming into the practice. So we think in this case the group has an opportunity probably to look at their, improve their documentation and coding. I didn't include slides, but we looked also at their distribution of major CPT codes. So we could see what proportion of the time this group billed a high-level discharge, a 99239, compared to other groups across the country, and found that this group bills a level 2 discharge, a greater than 30 minutes discharge, only about 10% of the time, whereas other hospitalist groups are billing that high-level discharge roughly half the time on average. So some big potential for improvement in documentation and coding, and also we think some improvement in the billing revenue cycle. So the fact that that number was so low caused us to look a little deeper into the revenue cycle, and we found that this group's getting a lot of denials for concurrent care, and those are not being aggressively reworked and resubmitted. So, so lots of opportunities on the revenue side there as well, and then potentially also some opportunities in terms of overhead costs related to billing and other expenses. So this is just designed to give you a little idea of how different folks use the data that's in the State of Hospital Medicine report and give you some ideas about how you can use it in your own practice. And then for the last few minutes, we want to talk briefly about some issues that we think you should consider when you're looking at data from the State of Hospital Medicine report, or really from any survey data for that matter. So the first thing is to keep in mind that there are a number of limitations to the data. The data is very good. It's the best that's available out there about what's going on with hospital medicine nationally. But it's important to keep in mind that the data is self-reported by hospitalist groups. Mostly those groups are members of the sponsoring organizations, SHM and MGMA. There is no independent validation of that data. Now, I will say that both organizations, SHM and MGMA, do have a process of contacting folks who submit information that is outlier information. In other words, if it exceeds low or high values that are set as being the most likely values for data, if a group submits data that are outside of those limits, then both organizations attempt to contact that group and verify that that was actually what they intended to submit. But generally speaking, there's no independent validation of the data, and we have to keep in mind that the survey respondent pool represents a relatively small proportion of all hospitalist practices nationally. As Tirza mentioned, probably around 14 or 15%. And so the data may not be representative in some cases of the larger underlying group of hospitalists across the country. Also important to keep in mind that the respondent pool varies a lot. So when we've got two sets of data in this report, the SHM data and the MGMA data, but those were two completely separate surveys with two completely separate respondent pools. So unfortunately, we can't take a data point from the SHM survey and a data point from the MGMA survey and divide them or subtract them or manipulate them in any meaningful way because they were two separate surveys and two separate respondent pools. The data respondent pool also varies from year to year. And as a result of this, comparison of results across years or across surveys may not always be entirely accurate. Nevertheless, with all those caveats in place, again, I'll reinforce, I think this data is really excellent data and the best we have available to us out there, and pretty reliable in most ways. Another thing to think about is that survey data always describes what is. It doesn't describe what should be. So we talk loosely about survey data in terms of benchmarks, but if you think of a benchmark as something you should be reaching for or striving for, survey data really isn't that, because it just says what people are saying they're actually doing out there, not what they should be doing. And a corollary to that is that all of this data is aggregate, and no aggregate data is going to precisely capture all of the unique things about your practice that makes your practice special and different. So keep that in mind as well. The data is backwards looking, not forwards looking, so it's not really an indication of future trends, and we often see things change rather dramatically from one survey period to the next. So when you think about interpreting the data, it's important to keep in mind that the distribution of the data isn't always a comfortable, convenient, bell-shaped curve. It's not a normal distribution. Very often when you're looking at things like productivity or compensation, for example, you have a lower limit of 0, but you have an upper limit that's more or less infinity. And so your bell curve, if you will, is often skewed way out to the right because you often have a relatively small number of groups that are way on the upper end of the productivity or compensation or whatever it is scale. So you'll want to pay attention to the standard deviation because it gives you an idea of how closely the data conforms to a typical sort of normal distribution. So if the standard deviation is less than the mean, you've got pretty close to a normal distribution typically. If the standard deviation is much higher than the mean or the average, that means that the data is sort of all over the place, and you can't rely on necessarily a good-looking, normal-looking bell-shaped curve. I'll also say that the median is usually a more useful metric to look at than the mean. The average values, the means, tend to be distorted by extremely high or by just a few extremely high or extremely low values. And the median is a much better indicator of central tendency in that regard. So we tend to report things and work using the mean much more often, the median. We tend to use the median to report information much more often than the mean. You'll also want to pay attention to sample size. SHM suppressed data for any cell where there was less than 10 respondents in that cell. But even so, you'll have some cells where maybe there were only 11 or 12 respondents. And we thought the data, there was enough data there to report, but you want to keep that in mind when you think about how credible or valid that data is or how well it might reflect what your practice should be shooting for. Another thing I would say is be sure that you understand the survey question and the way it was written. Sometimes the wording of the survey question makes a huge difference in how people respond to that question. And when you just look at the chart or the graph or the table, you may interpret the data incorrectly if you don't understand the question that actually got asked. So in the back in the appendix of the State of Hospital Medicine Report is the actual survey instrument itself that lists all the questions, and the survey guide that gives all the instructions about how people were instructed to fill out the survey. So that information is available to you in the report. And then another thing is that correlation doesn't mean causation. Just because two things move in tandem with each other doesn't necessarily mean that one causes the other. So I think a really good example of this is that both compensation and productivity tend to be much higher in the southern part of the country than in other parts of the country. And it's tempting to say, well, compensation is higher because productivity is higher, because they produce so much more, they can afford to pay more, or productivity is higher because compensation is higher. We're paying these guys so much money, and we need to make sure we get a bunch of productivity from them. And I don't think you can necessarily draw either of those conclusions. It may be that both productivity and compensation are high in the South because there's a lot of really small rural practices that are very hard to recruit to, and it's hard to get people to come there, so people work a lot of extra shifts and are highly productive and earn a lot of extra shift compensation, so their compensation goes up. I'm speculating, of course. There's no proof to that, but that's a good example of the fact that you can't assume that because two things move in tandem that one causes the other. Another thing about using the report is you should, my advice to you is to use the report as only one of many resources for the continuous measurement and comparison and improvement of your practice. So you want to look at things that will allow you to track your practice's performance over time and look at a variety of ways of comparing your practice performance externally to other groups' experiences. So some examples of things I can think of that you might want to use as other resources in addition to the State of Hospital Medicine report are, FHM has recently published the key characteristics of high-performing hospital medicine groups, and that is a really good way of sort of assessing your practice compared to an objective set of standards about what the practice ought to be doing in order to be an effective practice. There's also a similar document called Core Competencies in Hospital Medicine, which is really about the clinical competencies hospitalists should have and their scope of practice. I encourage peer networking among hospitalist leaders and among hospitalists through things like chapter meetings and just calling the guy at the other hospitalist group across town and saying, can we compare notes on some things? You should have a dashboard for your hospitalist practice internally that tracks your performance on a wide variety of metrics, not just financial metrics, but quality and service and utilization and other things, and allows you to trend your performance over time. And then there's lots of third-party data warehouses that your hospitals may participate in, organizations like Premier and Crimson that aggregate data for many hospitals across the country and can report back to you your group's performance on quality and utilization metrics compared to a reasonable peer group that's similar to you. So these are all really good ways for you to think about continuous measurement and comparison of your group over time. And then finally, we want you to think about how your group's unique characteristics explain potential variances from the values that are presented in the report. So questions you can ask yourself in that regard are, which variables and data cuts from the report are the most meaningful comparators for our group? Are we better off comparing ourselves against our own region or against other hospital-employed groups or private groups or groups of our size? So think about which data cuts are going to be most useful for you. How much validity is in that particular sample size? How does our group differ from survey data? Are there situational factors that explain some of the differences? Things like we might have a unique scope of practice, or this is a unique type of hospital that does things very differently. Where is our performance really out of line or different from what the survey data would suggest is the norm? And in that regard are the things we can do to change the way we perform and get closer to the survey, what the survey data suggests is more normal. And then how should we be measuring our performance against that variable? So that's just some things for you to think about the survey. And before I open it up to questions from people, I do just want to put in a plug to the folks that buy the survey. You can go onto the SHM's website, www.hospitalmedicine.org, and there will be a link for you to purchase the survey if you're interested in the full document, and you can purchase it either in a hard copy or in an online version, or both. And one thing I'll mention that didn't get mentioned earlier is I'm just so proud of the way the survey report looks this year. In previous years, you've had to put up with Joe Miller's or my attempts at organizing things and making it look graphically readable. And this year, SHM had professional graphics folks put together the charts and the tables and the pages, and it's in 4-color, and it's just a really attractive document. So I think you'll be really, really pleased with it when you see it. So with that, I'm going to turn it back over to Patrick, our organizer, and we can open it up for questions.
Thanks, Leslie and Tierza. That was a very informative presentation. Showed me some angles I didn't quite think of before, so thanks. Going back to your comment, Leslie, about the report being retrospective, I have a question that kind of goes along that lines. It says, what are the trends with private hospitalist groups and hospital-employed hospitalists? As hospitals want to control the flow of the patient, is there a trend for less private hospitalists and more hospital-employed hospitalists?
Well, I'm glad somebody asked that question, actually, because it points out something that I meant to mention and forgot to mention, which is it's tempting to look at the data in the SHM State of Hospital Medicine report and say, well, only X% of the respondents were private hospital medicine groups, so therefore only X% of the groups, hospital medicine groups across the country are private groups. And you can't assume that either from the data, because the data only shows which types of groups responded to the survey, not necessarily what the distribution of groups are that is out there as a whole. That being said, I think the proportion of private groups in the SHM survey has been going down slightly. And I would say from my experience that we are finding a phenomenon that hospitals, generally speaking, seem to be trending in one of two directions. They're either bringing the groups in-house and acquiring them and turning them into hospital-employed groups, or they're outsourcing their hospitalist programs to management companies. So I think, and again, this is purely anecdotal. It's not in the report, but it's based on my experience. I think that it's probably true that the proportion of private hospitalist groups that are out there is trending down.
Great. Another question. Since different programs have different standard hours for their shifts, is it possible to determine if there's a difference in encounters, RVUs and RVU/encounter among these various programs that have 8 or 10 or 12-hour standards with varying total shifts per year?
Well, let's see. I don't think the data was actually cut that way. I'm going to pull out my handy-dandy copy of the report. Let me say, first of all, that SHM doesn't ask about hours specifically, because that does vary so much by group. And many groups don't count hours at all, because they basically have systems where people work a certain number of shifts, and they are, they're sort of free to come and go, and they don't actually keep track of the hours worked by those hospitalists. So, but as I look for the data by, there is data on the number of shifts worked by hospitalists, and so we only broke it down by the generic scheduling model, so whether it was shift-based or call-based or hybrid. It doesn't really answer the question of do people who work more shifts, well, do different types of hospitalist groups work more shifts than others. I think I've lost myself in my data, but your question was specifically about whether the number of shifts you work or the number of hours you work generate less or more productivity. And again, that's a frustrating thing about having two separate surveys to work with. We can't cross over that information. So MGMA doesn't collect information about hours or shifts worked by hospitalists. and they're the ones that own the encounter information. So we can't really tell you whether the way in which hospitalists schedule themselves to work impacts the number of encounters.
Okay, and last question, and I believe it skirts that issue again. What percentage of hospitalists work in a VA or DOD? What percentage of those types of hospitals employ hospitalists?
Yeah, and I don't think we have that information either. There is if you look in the profile section of the hospital medicine report, there is, I believe, a section for government hospitals, but it doesn't break out VA and DOD specifically. And, you know, I'm not seeing that where that information is off the top of my head, but I know that there is a breakout in the demographic profile section of the report that shows the number of respondents that are government hospitals of one sort or another. And to be honest with you, I don't do a lot of work with VA or DOD hospitals, so I can't tell you from my own experience how prevalent hospitalists are in those settings. Tirza, I don't know if you would have any, Pat, you'll have to unmute Tirza's mic, but Tirza, I don't know if you have any insight into that at all.
No, we didn't really specifically ask about that. I think you answered it.
Okay. All right. Sorry, couldn't answer that one either.
Okay. I have an easier question, and you'll be excited to hear this. If our group didn't have a chance to be included in this year's survey, how can we ensure that we will be included in the future? Being that I will be designing the website, there will be a link that will be available that will put you on a list that will get your specific email added to the email that we send out asking for survey participation. And to remind you, if you participate in the survey, you do get a free hard copy of the survey. So on that note, I thank you both very much. It was a fantastic and interesting journey you took us on. This webinar, this recorded webinar, as well as the presentation slides will be available on the State of Hospital Medicine Report website. A quick link to that is hospitalmedicine.org/SOHM, and then click on SOHM survey, and you will see everything we have to offer there in the news section, some testimonials. It's a pretty interesting site. I hope you go and visit it. And if you have any questions, contact me, and I'll be happy to forward them on. Thank you very much.
Thanks, everybody.